Good morning, good afternoon, and good evening. I'm Mukta Sandhu, Senior Scientific Education Manager representing Geistlich Pharma, Switzerland. I extend a warm and gracious welcome to all of you for this webinar world tour series. I also like to welcome our speaker today, who's a power woman of modern dentistry, Dr. Sofia Aroca. If you're looking out for broadening the range of treatment for gingival recession coverage or thickening of soft tissue around the teeth and implants to prevent the appearance of worsening of the mucosal defects, Dr. Aroca will address this topic today, connective tissue substitute in aesthetic mucogingival surgery. She has specialization in periodontology and implantology at the University of Paris, France, and also she has done PhD. Since then, she has practiced only periodontology and implantology exclusively. Parallel to her private practice, she never stopped doing clinical research, teaching activities, and lecturing around the world. She's a member of Osteology Expert Council. So I extend a warm welcome to you also, Dr. Aroca, and the stage is all yours.
Thank you, Mukta, very much for your presentation. It's a great honor to be with you today, and hopefully you will have a lot of questions, and we can discuss at the end of my presentation. The topic that I will share with you today is connective tissue substitute in aesthetic mucogingival surgery. It is an extremely interesting topic because what we are talking about recession coverage or about implants. And I will focus, of course, first of all, on recession coverage. But recession coverage is a very wide topic, and the definition of recession coverage shouldn't be otherwise than this one. For instance, we can talk about soft tissue regeneration instead of recession coverage. Because soft tissue regeneration is our goal to reestablish the superficial periodontium. Can be done in this way with the substitute. Can we, of course, obtain a real integration of the superficial tissue with the adjacent existing soft tissue with the substitute of connective tissue graft? Let's go a little bit deeper in the topic. The definition of the gingival recession, all of us know what does mean, because we, in all the book, in all the publication, what we can read, that it is the apical shift of the gingival margin with exposure of the root surface, as you can read, to the oral cavity. But what does mean? What does mean that is an apical shift? But I think is more than that, is the loss of the clinical attachment and also the keratinized tissue is reduced when the patient presents gingival recessions. And if you keep this definition in your mind, you will, of course, you will understand much better why, since 2017 and published in 2018, the consensus between the AAP and the EFP is talking about soft tissue regeneration and not root coverage. Therefore, go a little bit ahead. This kind of gingival defect around teeth, usually we treat as a routine procedure. We use the connective tissue harvesting. However, the connective tissue harvesting can provoke an increase in morbidity. We can run the risk of having necrosis on the palate if we go a little bit deeper. Of course, the patient can present some bleeding and sensitivity changes. Therefore, it represents a discomfort for the patient. And also, which is really important parameter to take into account, the surgical time that we need in order to have a second surgical site. Therefore, that's why all the substitutes that we can have are extremely interesting in order to reduce all the risk that are associated with the harvesting of the connective tissue. But as a clinician, what should I or we can, because we are several to do that, what should we expect from an ideal soft tissue replacement material? That, of course, to be effective as the connective tissue graft, also to enhance the soft tissue healing, to increase the thickness of the keratinized tissue, and of course, to reduce what is extremely important nowadays, to reduce the patient morbidity. Can we have these results? Can we obtain this expectation from a soft tissue substitute? And by the way, what kind of soft tissue substitute we are talking about? We have several. You can see here all of these soft tissue materials represent, of course, possibility to treat this kind of gingival or soft tissue defects around teeth. But let's focus a little bit, and all of them that are showing a certain degree of wound healing and very nice integration, as you can see here in the study published by Anton Skulian several years ago. But let's focus a little bit more in the collagen matrices that we use nowadays in our daily practice. But how we can evaluate the efficacy of those materials that we know that really can integrate very nicely the soft tissue. But by the way, also how they can integrate very nicely and what they give us in our daily practice when we are using, of course, in our surgical technique. The most important thing that they are capable to stabilize the blood clot. And not only that, that's why they can, with the maturation, through the course of time, they can, of course, very nicely integrate into the connective tissue graft, by the way, become connective tissue grafts, of course, themselves. But just have a look in one of the very, very, very nicely utilized or very frequently utilized mucoderm and the randomized control studies comparing that. What you can see from this list of, it is, okay, you can understand it is in French, but in any event, we have several articles here that they compare the several different techniques, coronary advanced flap or tunnel technique with the use of the connective tissue graft for multiple recession. But if you really go into the literature, you can see that every time the connective tissue graft is the winner. And therefore, from those studies, you can see the substitute of the connective tissue graft in the instance this collagen matrix does not work really well. Okay, if we really go for the evaluation of the recovery of the defect. But let's go a little bit from a clinical standpoint. Here you see a patient with a very, but you can see it is not really a patient with a huge problem of recessions. But yes, she presented, she came because she has really an aesthetic problem and she wanted to improve her aesthetic, and she came to me, and she asked not to be treated with a connective tissue graft, but his dentist explained to her that how we can treat that, except that we have some possibilities to go without harvesting the connective tissue from the palate. Therefore, she came to me, but I am sharing with you the palatal aspect in order also to give you an idea which will be the surgical technique that we will use in this case. Of course, the tunnel technique, because it's extremely risky to place an incision in this kind of patient. Moreover, she has lot of loss of clinical attachment because she present mild or start to periodontitis. Here, by the way, you can see here the charting, and therefore this patient is not only must to be treated for her aesthetic problem, but you explain her that she is having a periodontal disease. Therefore, first of all, we have to stabilize the problem, and afterwards we can go for recession coverage or soft tissue regeneration around these soft tissue defects. And now you can see the patient after the initial treatment we stabilize the problem, but we have some pockets in the palatal aspect, and we combine the periodontal surgery, of course, in order to reduce the pocket on the palatal side, and for recession coverage. And in this case, I use one of the collagen matrices that we know very well and combining with the enamel matrix derivative. You see the time of suturing afterwards, 15 days after the surgery, and we go after the treatment, not after the recession coverage. You have the patient after the initial treatment, the baseline you saw, and here you see the final clinical situation at 1 year. This patient is not presenting anymore the recessions. It also is extremely stable in this area from a periodontal standpoint. But let's go a little bit more in more studies, comparing another collagen matrix that I use a lot. The Mucograft randomized control trial. I did several of those studies. I think we have our group has the longest experience using this connective tissue graft, the Mucograft. Therefore, you see also here, even if it is in French, this table, but what you can see, you see that if you go for the percentage on recession coverage, once again, the connective tissue graft is the winner. The connective tissue graft is the winner. Okay, just I give you this information. We will see a little bit later on why is important to take into consideration that these randomized control trials. Okay, here, let me share with you the first study that we did in order to evaluate, of course, the efficacy, the mucograft of this collagen matrix when in tunnel technique for to cover recession RT1 type defects. At that time, why I am a little bit hesitating, because of course, in the time that we published this article, the classification of the recession was another one, the Miller classification was used. Therefore, we treated patient with class 1 and 2 recession type defects, and we compared with applying the modified coronary advanced tunnel technique to cover recession, and comparing the collagen matrix and the connective tissue graft in a randomized control trial. Therefore, and we, of course, that is extremely important. Keep in mind this information that we did. We treat patients with maxillary recession and as well with mandibular recessions. And have a look here. Also, it's extremely interesting. Of course, the test was the side treated with collagen matrix, tunnel technique, collagen matrix, and the control, it was connective tissue graft. But just have a look from a statistical standpoint, the percentage of root coverage through the course of time, what we could evaluate, what we could observe on the test side, that the percentage of the recession, they were more and more covered, or we observe more percentage of root coverage. Just what I want you to keep in mind, that we have some dynamism that in the contrary, on the control side, where we used connective tissue graft, we had stability from the beginning. You see that we have some stability, and through the course of time, what we did not have with the collagen matrix. For me, it was extremely interesting. Why? Because I will show you, because this dynamism, this difference, this change in the percentage of root coverage was also illustrated from a clinical standpoint, not only from a statistical standpoint. And also you can see when we evaluate the complete root coverage through the course of time, we have somehow stability on the control side, because we have, of course, a little improvement in the numbers of sites that were covered completely compared to the test site. But also we had some increase in the numbers of recessions that they were completely covered. On the other hand, when we were measuring the width of the keratinized tissue, we did not have any difference between the test and control groups. Therefore, it was through the course of time, the increase of the keratinized tissue was the same. But just have a look here, what happens between the test. You can see that the test, mandibular recessions, very complex recession, position of the teeth, really a very reduced keratinized tissue. But just have a look on the test side on the lower incisor. Between 6 months and 12 months, we do not have any recession left. But of course, we have in percentage on the test side, we have less recession covered, okay? Because you could see in the tables the percentage. But just keep in mind that I am sharing with you on the lower arch, and you know, if you deal with recession coverage, that what is the difficulty on the lower arch to cover the recession. Okay, of course we do not go deeper because it's not the topic now to talk about the anatomy or the complexity of that. But just when we are, for instance, we have maxillary recessions. If I am telling you that on the right side you have the control and on the left side you have the test, you do not see the difference. And that it was for me something that it was extremely interesting. Don't keep in mind, RT1 recession type defects, we are on the maxillary, we are dealing with maxillary recessions, okay? We have some quantity of keratinized tissue apical to the recession. Okay, that just keep in mind. Therefore, I learned a lot when I was doing this study. And on the other hand, one of our colleagues, he was doing his PhD, and he evaluate also the post-operative wound healing. And for all the patients, the healing was extremely shorter on the test side compared to the connective tissue graft side, where we use, once again, we used exactly the same technique, and all the patients, the randomized controlled trial, and split mouth. Therefore, in all the patients, one side was with collagen matrix and one side with connective tissue graft. But in any event, we have really a very nice results in terms of the healing process, that it was fast and it was shorter, and the patient did not have any post-operative symptoms of problem. And the duration of the surgery, of course, and the patient morbidity were significantly lower on the test side, okay? And another study showing a multi-center studies where they evaluate the non-inferiority of the collagen matrix versus the connective tissue graft, and also the superiority in the oral health related quality of life, what we were also experiencing with the previous study. Okay, and they were 14 centers, 187 subjects, really a lot, with 485 recession were randomized, and for 6 months. And the surgical technique that they used, it was the coronally advanced flap. Remembered in the previous study was the tunnel technique. The results are what we also, my colleague, experienced. Shorter, the recovery, it was much shorter in the group of collagen matrix than compared to the connective tissue graft. And the complete root coverage was higher in the connective tissue group, but also here, this information keep please in mind, because it's directly related to my conclusions. And what we observe, of course, they concluded in this study that replacing, once again, it was a multi-center study, replacing the connective tissue graft with the collagen matrix shortens the time to recovery and decrease the morbidity, exactly what we show in our previous studies 5 years before this study. Okay, it's extremely important to keep in mind. Let's go a little bit further, because in the same study that I shared with you before, that it was published on 2013, and I have just shown the results of that. My colleague, Molnar Balint, evaluated the same patient at 9 years. I think it was submitted for publication, but already, of course, accepted. I forgot to take off because I was so excited to share with you this article, but it was, of course, already published. And you see here one of the patients of the study, the same. Therefore, all the patients were surgerized by the same surgeon. It was me. Therefore, I can really share with you this with a lot of excitement. Just have a look, the 9 years result you see on your left side, maybe for me is my left, you see the multiple recessions, and you see at 9 years. Therefore, of course, he could evaluate only 16 patients of the original 22 subjects, and therefore 114 sites they were examined. Have a look the test and the control. The test, we used the collagen matrix, and the control was the connective tissue graft. Baseline on the control, just in order to show you very quickly that we did the tunnel, we placed under the tunnel the connective tissue graft. Of course, before we started the surgery, we closed the contact point in order to suspend the suture, as you can see here. And you have 1 year result. Therefore, from 1 year, we passed at 9 years. You see that it was almost no change between 1 year and 9 years. We are talking about 31 recession type defects on the upper arch. Keep in mind, with a certain quantity of the keratinized tissue apical to the recession. It's extremely important. And the baseline situation was this one. Okay, so let's have a look on the test side where we use the collagen matrix exactly in the same way that we place the connective tissue graft under the tunnel. We place the collagen matrix under the tunnel. In the same way, we close the tunnel, donc with the suturing technique around the contact point, and just have a look here around what will happen with the width of the keratinized tissue on around the cuspid. 1 year result, the 1 year result, you see maybe I cannot show you. Yeah, I do not know if you see the arrow here. We have relapse, a little relapse of the recession here, but it cannot be any more observed at 9 years. Therefore, you see, do you remember that I was telling you that we can observe some dynamism on the side where we do use collagen matrix from the baseline and 9 year results. Okay, but our results, I was showing you in purpose on the maxillary side, 31 recession type defects. Remember that we put together, according to the Miller classification, Miller 1 and 2 recession type defects. It's extremely important to make the difference. Therefore, at 9 years, of course, the mean root coverage was a little bit lower on the test side and compared to the control side. After 9 years, it was observed in 2 patients, 1 in each group, the complete root coverage, what I was showing you, not because I wanted to show you that how smart we are or what we can do with our hands. Not at all. It's really, really, really extremely important to take in consideration with the results. But of course, the connective, the keratinized tissue with increase in both side test and control, and that is extremely, this information is important. The outcomes obtained in maxillary areas, means upper jaw, seem to be more stable compared to the mandibular ones. Okay? Okay, you will tell me, okay, but we know that in mandibular is a little bit more difficult to obtain results. But at 9 years, stable results. I mean, at 9 years, the relative stability is equivalent in the 2 groups. Also keep in mind that. Therefore, according to you, which are the determinants for long-term success? Therefore, in other words, can you go really in a safely way to substitute the connective tissue graft? And if it is so, what are the determinants that you have to take into consideration in order to be predictable? The surgical technique, the baseline clinical parameters, the location of the recession defects, mean maxilla or mandibular, or the material that you use, means collagen matrix or other substitute, because it's not we do not have only collagen matrices, but what I was working with so far, it were the collagen matrices, or the patient maintenance. What do you think it is the most important one? Okay, for the surgical techniques, you know, I do not go deep in this topic, only to tell you that we have the evaluation, which surgical technique you can use in order to treat, is based on the evaluation of clinical parameters and not on the product or on the connective tissue that you will use. Is based on really clinical parameters. Therefore, if you want to go a little bit more deeper inside, you can go for the articles. Just very quickly, the modified coronal advanced tunnel technique that we normally use, but you can use also the multiple coronal advanced flap. If you are dealing with multiple recession, you can, but only very, very quickly, you can see that the tunnel technique that I usually use is the modified coronal advanced tunnel technique, that the elevation of the tunnelized flap is in full thickness manner. And you go deep beyond the mucogingival line, and afterwards with a blunt curette, you will extremely, in a gentle manner, beyond the mucogingival line, you will cut very gently the collagen fibers or the muscle fibers that you can find in order to reduce the tension of the flap when you advance in a coronary position. You can see here how you go a little bit deeper, but with a blunt curette, in order really not to damage and not to run the risk to perforate the flap. And at the end, you elevate the papilla. You trim the collagen matrix as in the same way as you do with the connective tissue graft. And afterwards, with the help of the sutures, you go under each papilla. Of course, you have to pay attention from which side you will place into the tunnel the connective tissue graft or the collagen matrix in this way. And in this case, is the wider recession is around the molar. Therefore, of course, you place from the wider recession with the help of the sutures. You come back, you could see that we enter and we we enter, we take either end of the collagen matrix and we pull. Okay, the movement is a little bit exaggerated, but you can see very nicely that we can pull very easily into the tunnel. And we, of course, we fix in majorly in distally the collagen matrix in exactly the same way that you do with the connective tissue graft. Afterwards is the one of my preferred suturing technique, horizontal matrix suture at the base of the papilla. Afterwards, you suspend around the contact point, closing the short end under the loop, and you close. And when you close, of course, everything advances, and it's extremely important when you are using collagen matrix. You have to cover completely the collagen matrix. Therefore, is the behavior, the biological behavior of the collagen matrix is exactly not the same. Only to show you that the surgical technique itself is not really the most important determinant. You see here, we published recently also a study where we randomized control study with an evaluation at 12 months when we use the volume stable collagen matrix, the Bio-Gide, for the treatment of RT1 recession type defects. You see that we on my left hand the coronally advanced flap, and on my right hand the tunnel. But in order to see that, you can see from the clinical picture, also you can read, we had exactly the same result. But what it is extremely important to take in consideration, that the phenotype with this kind of substitute, the phenotype can be, of course, modified. For the recession coverage, we will talk the mean percentage of the recession coverage. We will talk a little bit just later on. But what is important is to take into consideration that we can obtain exactly the same. Therefore, the surgical technique itself is not really the determinant. But in which instances, the clinical, of course, instance or clinical situation, according to our experience, according not only our clinical experience, but according to what you can find in the literature, in which instances you can use and indicate the substitute. Can we obtain complete root coverage with them? Just have a look. I put in the first row, you can see the connective tissue graft. If you are dealing with RT1 recession type defects, RT1 multiple or single recessions, the connective tissue graft, of course, it works. And we know it is the gold standard. The collagen matrix, having RT1 recession type defects in single recession, it works. According to me, if the location, according not to me as a clinician, but according to what we had as a result and observation when we were performing randomized control trial, of course, the collagen matrix can be used, whatever the collagen matrix that you saw, also the acellular dermal matrix, also the enamel matrix derivative, and also the acid hyaluronic in single recession. But when we are dealing with RT2 recession type defects, it changed a little bit when we are dealing with single recession. And you see that you cannot have, it's not observable in the literature that the enamel matrix derivative in RT2 recession type defects give you a predictable result. So far, I am not telling you it's not possible, but so far, RT2 recession type defects means with loss of interproximal clinical attachment. Okay, and in RT3 recession type defects, also the connective tissue graft is not, whatever be the surgical technique, is not predictable. And anything is predictable in RT3 recession type defects. The last is the connective tissue graft. Okay, if we evaluate the thickness, excuse me, it is in French, but if we are evaluating the thickness of the surgical technique, of the result of the surgical technique, the thickness of the phenotype, as I mentioned before, we are really predictable, and we do not have any difference between the connective tissue graft and the collagen matrix that we use. We can modify, but we do not modify the phenotype only with the enamel matrix derivative or with the hyaluronic acid. And the width of the keratinized tissue, of course, it is increased with the collagen matrices as well as the connective tissue graft. Therefore, the modification of the phenotype is exactly the same when you use substitute of the connective tissue graft. But it was not demonstrated with the enamel matrix derivative or with the acid hyaluronic. Therefore, and what about the multiple recession? The multiple recession is exactly the same when the RT1 recession type defects. And you can, of course, you can use, but you see, if I am telling you from a clinical standpoint that you are predictable using collagen matrices, the instance of the collagen matrices, because I worked a lot, once again, with that. If I am telling you that is not really, not every time you can reach, you can achieve complete root coverage, because the studies are showing you that. And why they are showing you that, the studies, exactly the same with the acellular dermal matrix. And of course, only to associate enamel matrix derivative without the use of the connective tissue graft. Now I am telling you only the flap and the substitute. That's why we have in this table what it works without connective tissue grafts, okay, or replacing the connective tissue graft. And when in multiple recession, the enamel matrix derivative, according to the literature, is not really predictable using alone. Excuse me. On the other hand, when it is associated with the connective tissue grafts, the enamel matrix derivative and the acid hyaluronic works, and it was not demonstrated so far for the acid hyaluronic when you deal with RT3 recession type defects. I think that is a little bit too much sharing with you, but let me tell you, we have some advantages, and a lot, I think, with the use of the connective, when we replace the connective tissue graft with the collagen matrices. Of course, the quantity is unlimited. Of course, it is one of the advantages. Reduce the surgical time. You could see reduce also the morbidity. It was not showed only by us, but a group of the multi-center with 40 centers that reduce the surgical time. The tissue blending, the phenotype modification, keep in mind the phenotype modification is exactly the same. I am not a seller. I am not promoting product. I am promoting science. I am promoting the results of our studies. Predictable results we can obtain as long as it is used in the right indication. And what is the right indication? What is the right indication? Therefore, the determinants are not the surgical technique, of course, not at all the surgical technique, but yeah, it's just but the baseline clinical parameters, the location of the defects, and the patient maintenance. Therefore, it means, guys, it means that if you want to use a substitute, for instance, the collagen matrix, of course, they can represent a future option for replacing the connective tissue graft, as long as is indicated in the right clinical situation. What does it mean? It means, according to our experience, our not clinical, I am repeating myself, but when you are dealing with RT1 recession type defects, you are in the maxilla. Remember, the 9 years result show more stable result in the maxilla. And also when you have at least 1 millimeter of keratinized tissue apical to the recession, I think with closed eyes, you can replace the connective tissue with the collagen matrix, excuse me. Or also, it is very interesting that these collagen matrices can serve as a scaffold for other soft tissue regenerative materials, as for instance, as we associate the enamel matrix derivative with the connective tissue graft, we can associate also it. I think it was shown with wonderful studies from the group of Bern with Professor Esculian, that also very nice results obtained associating the acid hyaluronic with the connective tissue or with the collagen matrices. Therefore, it was what I wanted to share with you. Keep in mind that you can use and you have a lot of predictability as long as you, of course, maintain the patient under a support, a periodontal support. And with that, thank you really for your attention. Hopefully that you are still here and we can discuss a lot, and hopefully you have a lot of questions. And thank you very much for your attention once again.